So Dan, sometimes we do a biopsy and we're not quite sure based on imaging alone whether we have obtained a diagnostic sample. How can looking at the sample help you?
Yeah, Paul, I think this is a helpful tip because, we showed a few examples of small lesion biopsies. This is another example. I think this is the smallest liver lesion that I've ever biopsied, 6 millimeters. You can possibly see it well in ultrasound. You can try to target as much as you can with your first pass. But once you've done your first pass and gas is introduced in the vicinity of the lesion, it's very hard to be confident that your needle was in the right spot. So always be comfortable and be more confident at looking at your specimens. I like to lay them out on a TELFA pad, and I like to look at them closely to see if I find that I was in the lesion or not. You can see here very clearly that in the middle of the core specimen, we have a white tan discoloration. That's representative of the liver mass we just biopsied. And the more red and a little more color at the tip and at the proximal end of the core specimens, the specimen actually correlates with the normal surrounding liver. So be comfortable by always checking your specimens as you obtain your cores. This is another example of a patient with rectal cancer, had new liver masses. And by looking at the core specimens, we're pretty convinced, especially that abrupt change in the coloration of the core specimens shows you that there's progression between the normal liver, the surrounding, the parenchyma that is compressed surrounding the mass, and also the white tan that usually denotes malignancy in these biopsies.
That's a great tip, Dan. And the other thing to think about is that necrotic tissue can be white, but it tends to look cheesy and it's very friable and it tends to just disintegrate on your TELFA pad or in saline or formalin. Also, hemorrhagic necrosis looks like old bloody material, and it also tends to disintegrate. And then fatty liver can be a little bit confusing because it is lighter in color. And so, getting used to looking at your specimens will, as you get experience, you'll get better at making those distinctions. But nothing's better than that abrupt cutoff of normal versus abnormal tissue.
That's great. Another, typical example is patients with metastatic melanoma. This is a patient that had an FDG-avid liver dome mass that we targeted under ultrasound. We were able to get the needle in the right spot. We were confident that we were in, but by looking at the core specimens, you are completely convinced that we're dealing with metastatic melanomas because you can see the melanin pigment within the lesion. That happens in melanocytic melanoma.
Dan, that looks like you took a welding torch to it.
That certainly looks like it. There's another example of a patient with suspected metastatic melanoma, had new liver masses. We targeted under ultrasound, and we could see the core specimens really dark, which is diagnostic of metastatic melanoma. The other thing that makes me confident that we're in the lesion, not only by looking at the core specimens, is looking at the post images. I always tell the trainees, when you're doing biopsies, you want to have imaging before, during, and after. And what you're going to look at on the after images is not only the presence or absence of complications, but also looking at your biopsy needle tracts. And here you can clearly see the biopsy needle tracts within the mass, which makes you more confident that you were in the lesion.
Absolutely.
That can also be helpful in occasions where the lesion is very inconspicuous, very difficult to see. This is a lesion that was nearly isoechoic to the surrounding liver. We were able to, by using color Doppler, looking at the adjacent vessels, get the needle in the right spot. We were confident that we were in based on anatomical landmarks, but it was really hard to see the lesion. But only after looking at the core specimen, seeing that the abrupt transition that you mentioned, Paul, that I felt really confident that we had diagnostic specimens.
Great example.
And this is a little bit of a more unusual case of a patient, a 43-year-old female patient that had right upper quadrant pain. She had a liver ultrasound that showed a heterogeneous mass in the liver. That led to an MRI. The MRI showed a fat-containing mass in the liver. It felt like it was probably abutting the liver capsule rather than originating from the liver. It also had this particular nodule within the mass that was very diagnostic on the ultrasound. If you could show the ultrasound, you can see there's very hyperechoic with shadowing. It resembled very much a Rokitansky nodule or the tip of the iceberg sign that we can see in pelvic ultrasound. The patient was seen by a sarcoma expert here at the Brigham and was referred for a biopsy to roll out a liposarcoma. Once we got the needle in position, we started to see some liquid fat coming out of the needle. And when we pulled the needle from the nodule that we biopsied, we could see a lot of hair. And that was, immediately diagnostic of a teratoma. We almost canceled the pathology consultation on this one.
Yeah, I could have saved the patient thousands of dollars. That's awesome.
Absolutely. As it turns out, this was a mature teratoma of the liver. And the patient had had a pelvic surgery when she was 14 years old to remove a large teratoma. And there was some spillage of teratoma into the peritoneal cavity. Well, can you, now that we have an approved ultrasound contrast agent in the market, do you think we could use that for diagnostic, for interventional procedures as well?
Yeah, absolutely. So, what I would suggest is if you haven't already been using it, start off using it with some large liver masses to kind of get comfortable with it, to kind of get used to the timing and the workflow. And so, for example, this is a large mass that we see on PET-CT. And under ultrasound, it's actually relatively isoechoic, although you can kind of faintly make it out. But you can see with ultrasound contrast, the metastasis washes out and becomes hypoechoic and is nicely targetable under ultrasound. One thing I think ultrasound contrast is going to do is it's going to make it even easier to keep liver biopsies in ultrasound and not have to rely on CT, at least much less often. And even with very large tumors, this is a large tumor that has extensive necrosis. And under ultrasound, you can see the mass, but it's a little bit hard to distinguish, which are the viable and which are the necrotic areas. And so we used contrast, and you can beautifully see the areas that are enhancing and the necrotic areas that are not enhancing. So we just targeted this enhancing area, and we're confident that we got a diagnostic specimen. And of course, where it really shines, the contrast is for these small liver lesions, like this 1 centimeter liver metastasis. And when we looked with ultrasound, we looked very carefully, but just could not see the lesion. And so we used contrast, and sure enough, it washed out, and we're easily able to target this and get a diagnostic biopsy. I've used it a little bit in the kidney. This was a patient who had an MRI. He had both acute on chronic renal failure, and his eGFR was extremely low, so they didn't want to give IV contrast. And so the MR was read as suspicious for renal cell carcinoma, but there was some question about whether it could be a complex cystic mass. And so what I did was started with contrast ultrasound to just make sure this was really an enhancing mass. And you can see the contrast coming into the kidney and rapidly enhancing this mass. So then we went ahead and biopsied it under CT. Could have biopsied it under ultrasound also, but wanted to use CT just to kind of stay away from the sinus area of the kidney.
Can you comment on endocavitary ultrasound for biopsies, Paul?
Sure. So, being comfortable with using an endocavitary probe and the biopsy attachments is very, very helpful. And even though you don't need it every day, it's just the best way to biopsy some of these cul-de-sac or vaginal cuff masses. It's a not unusual scenario. And then what happens is anteriorly, the bladder and bowel and blood vessels can make it very difficult to approach these. And posteriorly, you may or may not have a window. So the endocavitary approach can be just perfect. And you can see on this sagittal reconstruction what a straight line approach it is coming through the vagina to the cuff region for this mass. And so here was our endocavitary probe in the fornix, and doing the needle placement under real-time ultrasound to get a diagnostic biopsy of this tumor recurrence.
Beautiful.
And of course, we can also use CT contrast in a variety of ways to confirm needle placement. We've already shown an example or two. This was one example where EUS, endoscopic ultrasound, was not able to identify a pancreatic head mass, and they were not able to do the biopsy. This was despite the fact the patient already required a biliary stent. And so we were asked to biopsy under CT, and we could see this tumor that was encasing the mesenteric vessels. Really couldn't appreciate tumor in the pancreatic head, although presumably there was some infiltrative tumor that had reached the common bile duct. So what we did is we just first under CT fluoro placed our fine needle introducer and coaxial FNA needle into where we thought we wanted to biopsy, and then gave contrast to confirm. Actually, ultrasound didn't work in this case because the tissues here were very indistinct and the vessels were so narrowed that they weren't as helpful as landmarks. But the contrast enhanced CT showed us that we were in tumor, and we got a diagnostic biopsy here.
Nice. Yeah, this is another example where I think IV contrast was really helpful, because you can see the lesion fairly well with the contrast enhanced CT. But once we brought the patient to the CT room, with the non-contrast CT, it was really hard to delineate where the lesion was. We placed the needle using anatomical landmarks very close to where we thought the lesion was. We pulled the inner stylet and we injected contrast. We could see that the needle tip was at the margin of the lesion, which could be helpful to obtain diagnostic specimens, but still, having that confidence of where exactly the lesion is was helpful, because we then repositioned the needle and we got core specimens where we thought where the lesion was located. And then always, as I said, the cherry on the cake is looking at the gas bubbles within the mass, which shows us that we were obtaining specimens exactly from the lesion mass, from the mass lesion that we saw. And this is another example where injecting contrast can be very helpful.
As I recall, Dan, this mass was almost isodense on non-contrast CT, so the contrast was really spectacularly confirming the right placement of the biopsy needle in this cholangiocarcinoma.
Perfect. And this is another strategy when you can't see the lesion well, and you could potentially avoid injecting IV contrast. This is a patient with a history of adenocarcinoma of the colon, had a small lesion that was very well seen on the MR, restricting on segment 2. We couldn't see the lesion on CT. We placed the needle using anatomical landmarks very close, the introducer needle very close to where the lesion was. And this is an alternative that we have, unfortunately, we have at the Brigham, which is calling the cytopathologist intraprocedurally to check for a diagnostic specimen. So they actually review the slides as the patient is lying on the table, and they were able at that time to confirm that we had lesional cells and that the biopsy was actually diagnostic. So that was really helpful, and something that you could use in selected cases. It does add some time to the procedure because the pathologist needs to come, review and prepare the slides, but it does give us confirmation that we had lesional cells. I like to use that not only in cases where I can't see the lesion well, like in this example, but also in cases when the first biopsy was non-diagnostic, the patient is coming for a second time. You don't want the patient to have to come for a third time. You want to really make sure you have diagnostic specimens. Having the pathologist on site can be very helpful in those circumstances.
Yeah, that's a great point. A second non-diagnostic biopsy is the worst. So Dan, I think many radiologists are reluctant to perform splenic biopsies. What are your thoughts on that?
Yeah, I think that fear can be justified by the historical description of the spleen as being a bag of vessels. I think, now with so many publications and series having published on splenic mass biopsies, I think we can get pretty confident in performing those. The risk of a splenic mass biopsy by using 18 gauge needles that we typically will use for biopsies elsewhere in the abdomen is very similar to the risk of doing liver mass biopsies and even renal mass biopsies. So that is not completely justified, particularly in cases where you have large masses that are actually abutting the capsule. in which case you don't really necessarily need to go and traverse normal splenic parenchyma. And this one, a typical example of a patient with a large mass in the spleen. You can see how the mass is actually traversing all the way into the capsule and almost penetrating the abdominal wall there. And we were able, by using ultrasound, to just get your biopsy needle straight into the mass and not really traversing any of splenic parenchyma. So, and we know, obviously, no complications, as you can see in this post biopsy images. When you do have to traverse some splenic parenchyma, it may be helpful to use ultrasound and choose the path that will minimize the amount of traversing parenchyma. So in this example, patient had an FTG avid mass in the spleen. We couldn't see the lesion on CT. We brought the patient to ultrasound. And there were two options. You could do the biopsy coming from the left to the right or coming from the right to the left. We chose the path that would minimize the amount of traversing parenchyma. And that's another point that I wanted to make, Paul, is always helpful to test using both hands so that you're comfortable doing procedures with left or right hand. Because in a situation like this, you want to really choose the path that is less risky for complications. So we ended up going from left to right, minimizing the amount of parenchyma that we were traversing. We got diagnostic specimens. This was confirmed a lymphoma, and we had no complications post-procedurally, as you can see on that image. Unfortunately, that's not always the case. Sometimes, especially if the mass is very high up, this was a mass in the upper pole of the spleen, we had to traverse quite a lot of parenchyma. We try to minimize going through the large vessels, but unfortunately the patient had a little bit of bleeding after the procedure. You could see a pseudoaneurysm on the post-procedural images. We obtained a CTA to make sure there was no active extravasation. Unfortunately, there was a little bit of active extravasation. The patient was admitted overnight and managed conservatively, and she was discharged the next day after a blood transfusion, and recovered well. And what about PET-CT, Paul? And we use it a lot for diagnostic purposes. Do you think it's helpful to use PET-CT for interventional cases too?
Yeah, of course, I love using PET-CT for intervention, especially ablations. But in general, the approach is to only use it if you absolutely have to, for obvious reasons. It's a limited resource, more expensive. And, in most cases, you can correlate with the PET-CT and just use anatomic landmarks on CT or ultrasound to do your procedure. But once in a while, certain musculoskeletal cases and even liver or kidney cases, it can be helpful to use PET-CT guidance for the actual procedure. This is a patient that had presented with a new large splenic mass and no previous history of malignancy. When you looked at the mass, it was actually heterogeneous, but it looked the same all the way throughout the spleen. But interestingly, on the PET-CT, there was just one focal area that was really intense, and the rest was just kind of mild to moderate activity. So we really wanted to, since we were going to biopsy the spleen, we really wanted to biopsy this area, and it was going to be hard to do that based on landmarks alone. So we did this under PET-CT guidance, and you can see that we placed the biopsy needle right in this FDG avid lesion. And one of the things that we do to make sure we have good co-registration of the PET and CT so that we know that this activity is actually in the same location as the needle as shown on CT is we do our PET-CT in breath holds, a single breath hold where we get both the PET and the CT acquisition. And something that not everybody appreciates is that even a 15-second long PET acquisition often has enough counts to show the exact location of a focal lesion. And so you can get a breath hold PET-CT where both the PET and the CT are required in 30 seconds. Or if they're under anesthesia, you can make it a little bit longer acquisition. That turned out to be, by the way, an angiosarcoma of the liver. But, we didn't know if this was like a more aggressive area of lymphoma, for example. So that was one reason we did this targeted biopsy. This was another patient that had a history of malignant melanoma. and also had a history of an indolent lymphoma that did not require treatment. And on the restaging PET-CT scan, this was the only spot in the body that lit up. So we decided to do the biopsy under PET-CT and ultrasound guidance, partly because we were also planning to ablate this lesion in the spleen. And you can see it's right under the diaphragm. And fortunately, it was visible on ultrasound. So we placed a 13 gauge introducer in the spleen. And through that, we obtained 18 gauge core biopsies, which interestingly showed both lymphoma and melanoma. And so my suspicion is that this spleen probably had diffuse infiltration with this low-grade lymphoma. And this happened to be a focal melanoma metastasis. So then we switched out the biopsy needle through the introducer for a microwave probe and ablated the tumor. And the PET-CT was helpful in showing the ablation zone encompassing this metastasis, which actually has not recurred in over a year. I'll just say a little bit about fatty masses. Fatty masses are usually very safe to biopsy. One of the common scenarios is when we're diagnosing or trying to diagnose liposarcoma. And we all know that we want to biopsy the denser areas that are more likely to be less well differentiated and easier to make a definitive diagnosis on. But the point I really want to make is that when you do a core biopsy of a fatty mass, a lot of times the samples are very stringy or friable and not very substantive. And so I have a very low threshold to go to a 16 gauge core biopsy needle for these fatty masses to help get a definitive diagnosis if I think it's safe.
That makes sense.
Sometimes deep pelvic targets are hard to get to. And let me just show one example here. So this was an elderly lady with acute diverticulitis, and she came in through the emergency room and had this perisigmoid abscess at the top of the sigmoid loop. And you can see that anteriorly, there's clearly no access, laterally, blood vessels and bowel in the way. And even as you come down posteriorly, there's nothing on the right side, but maybe on the left, there might be a parasacral approach if you angle up, but it's a pretty tight window. And the other thing is, if you're going to do this, you have to think about what's going to happen during the procedure. So for example, if you get your needle up here, or even right here, and then put in your guide wire, the guide wire may just go up in this crevice and not want to cross over into the dominant part of the abscess. So what I thought was I really wanted to get my needle kind of down here, entering the collection kind of in the middle under the sigmoid loop, so that the wire hopefully flops over into the right side of the abscess. And then it's just a question of angling up through here. So when we had the patient on the CT scanner prone, we obtained a planning scan, and you can see the abscess here. It's kind of subtle on non-contrast, but we, based on landmarks, including diverticula, kind of knew where we wanted to end up, which was somewhere right about here with the tip of the needle and coming from the left side. So we, under CT fluoro, just angled out of plane. We did not angle the gantry, just working out of plane, sort of incrementally advanced the needle under CT fluoro. We got the needle about where we thought we wanted to be, and then decided to do a CT with contrast. And what I found was that the tip of the needle was indeed too much on the left side. And if I had put in the guide wire, well, first of all, if I had advanced the needle further, it probably would have poked the bowel or a diverticulum. And secondly, the guide wire would not have wanted to cross over. So we just repositioned more inferiorly and medially, and then the guide wire nicely flopped over into the right side, and then we dilated and got the catheter loop in place. You know, nice final position of the catheter. She did really well. Her symptoms resolved quickly and avoided surgery in this case. You could also have angled the gantry to get up here. That's another approach, or using multiplanar reformats. And, you know, just some examples of angling the gantry. So this was a biopsy, a research biopsy for a clinical trial. And this was a low pelvic mass behind the bone. And so we angled down out of plane for the first biopsy and got the tumor. But then when the patient came back for their repeat biopsy, the approach taken was to angle the gantry so that you could see almost the entire needle trajectory on one or two images. And so that was another nice way to do this difficult pelvic biopsy. And then, Seldinger technique, I'll just briefly talk about that. So this is something that is widely used. And of course, one of the big advantages is when you need to navigate between critical structures, it's much easier to do with a needle as opposed to trocharring in a catheter. And so once your needle gets past the critical structures, then you put your guide wire in and deploy the catheter. But the other thing you can do with Seldinger is use the guide wire to access a remote location, even through a narrow channel sometimes, and that can be very helpful. So, for example, you can access a superficial collection and then direct the guide wire with your needle or even with a stiff dilator so that it goes through a channel into a deeper collection and then dilate and put your catheter in that way.
Nice.
This was an example where we needed to drain a subphrenic abscess, but we didn't want to go through the pleura. And we saw an access point that was actually quite low in the mid-abdomen. And when we got our needle in here, we just directed the needle towards the head and then advanced the guide wire and ran it all the way up to the subphrenic space. And then you can see how the catheter traveled all the way up into the anterior subphrenic space for a good drainage. So Dan, I know you've seen an interesting case where they went transpleural for an liver abscess drainage.
Yeah, I think this is a good example of, the short path is something that we always look forward to doing it, but it may not be the safest path. This is a patient that was transferred from an outside hospital. She had a liver dome abscess, as you can see on the non-contrast CT, and she was referred for catheter drainage. They decided to perform the biopsy under CT and decided also to maintain the needle link plane and go the shortest path using a prone position, posterior approach, and they got the catheter, percutaneous catheter, using a transpleural approach. The procedure, post-procedural images were satisfactory. There was no complication, but obviously you can clearly see on the sagittal images that they had to go transpleural, intercostal, and definitely transpleural to get to the liver abscess. And unfortunately, a few weeks after, the patient was readmitted to the hospital with a large empyema. You can see, large or moderate-sized pleural effusion, some atelectasis, the catheter clearly going intercostal, transpleural into the liver dome abscess. Whenever you can, you want to try to avoid a transpleural approach or intercostal approach. Sometimes it's unavoidable, and if you have to do a drainage, particularly in a liver dome mass, and you have to use an intercostal approach, it's very helpful to consent the patient for the possibility of this complication, consent and also inform the referring team that there is a high risk that this patient may develop an empyema. And occasionally, especially if the patient already has a pleural effusion, you can occasionally place a catheter, a pleural catheter at the time of the procedure at the same time. So as you're placing your drainage catheter in the liver dome or the liver abscess, you can also place a catheter for the pleural effusion as well.
Yeah, and the other thing is if they don't have a pleural effusion, just follow with chest x-rays, and if they develop one, then consider draining early so that it doesn't end up in a situation where the patient needs a decortication.
It's a great point. This is an example of a liver dome abscess in a patient that was 80 years of age, AML, had a prior bone marrow transplant, was presenting with febrile neutropenia, and had a small, new but small liver dome lesion. We brought the patient to ultrasound. We could see the liver abscess. It was very small, actually smaller than the distal loop of the catheter, which is typically 3 centimeters. The abscess was only, I think, about 2 centimeters in size. So rather than placing a drainage catheter, we decided to do an aspiration drainage by using an 18 gauge needle. And we were able to get 2 to 3 ml of pus. That was helpful for decompressing the abscess, but also providing material for microbiology, for culture, and sensitivity for antibiotic coverage.
Yeah, that's great. I think, many small liver abscesses don't require catheter drainage. And as long as we have the culture and sensitivity, they can be managed with IV antibiotics. So that's a great example. Dan, I know you sometimes use air or contrast to assess fluid collections during procedures. Can you show us how you do that?
Absolutely. I find this helpful in selected cases. This is one where I used it. The patient had a small pelvic abscess. We were able to place the needle very rapidly with an 18 gauge Chiba needle within the collection, but we just couldn't get anything out of it. Sometimes you're fooled by the imaging and you think your needle tip is inside the collection, but you're actually tenting or pushing against the wall. We were pretty convinced that we were in. So one way of confirming that you're in the right spot is by injecting air. Usually I put about 5 to 10 ml of air. I inject in the collection. That serves two purposes. One is you're confirming that your needle tip is in the right spot, like within the collection, but it also assesses the quality and the viscosity of the collection. And you can see in the lung windows here how that collection was very complex. There's a lot of very thick material within it. And it was helpful to, confirm or at least explain why we were not able to drain anything from it. This is another example of a 28-year-old that had an empyema, was referred for catheter drainage. We placed the needle, it was actually a synthesis catheter, in the pleural space. We were not able to withdraw any fluid. We were not able to push the wire in, and I thought that we could potentially be extra pleural. So we decided to actually inject a little bit of air to confirm our location. And injecting air, a little bit of air, we were able to see that the air diffused within the pleural cavity. We were convinced that we were in the right spot and thus able to get the wire through and finally place the drainage catheter.
That's a really cool example, Dan. I think, clearly your needle was in the pleural space, or the only question was, could it be, more extra pleural? Obviously the one caveat is you would never want to inject air into the lung itself because of even though it's a small risk, the theoretical risk of air embolism.
Absolutely.
So I'll talk a little bit about this curved trocar technique that we described in 2017. And this can be used with any all-purpose drainage catheter. You just pre-bend it and use CT fluoro to insert it. Obviously, if you're using ultrasound guidance, there's no gantry restrictions, so you don't have to pre-bend the catheter. And the way I do this is I just create a series of small bends. I don't want any abrupt acute bends in the catheter. And pretty much you want the entire catheter to have a gradual 90-degree curve so that when you put it in the skin, your hand is well out of the CT beam for CT fluoro. And so this is kind of what it looks like. And then when you put it into the skin and move the patient into the CT gantry and do CT fluoro, you can point the catheter in any direction you want and confirm the trajectory with CT fluoro, and then reach in with your other hand and incrementally advance the catheter very safely and precisely. So I like it because it's a very fast and accurate technique, very safe. So for example, this is a patient that came to us with a tension pneumothorax after surgery, and he was in acute distress and he could hardly lay down. So we put a grid on, we did a quick planning scan, and then immediately sat him back up and did our prep drape with him sitting up, and even local anesthetic and incision, had all our supplies ready, and then laid him down, put the catheter in the skin, and then under CT fluoro, had the catheter in the pleural cavity within about 20 seconds. So very, very fast way to get a catheter in. And then we had him sitting up in less than a minute. And then, so obviously curved trocar or any trocar technique is great for large superficial collections. But paradoxically, I find that even for small collections, it can be very useful because there's so little room to use a guide wire. When you have a collection this small, the guide wire is more of a problem than a help. And so under CT fluoro, You put the catheter in the body wall, correct the angle under CT fluoro, and incrementally advance it into the collection, and then deploy the catheter and make sure the loop and all the side holes are in the collection. So that was the lower collection. And then there was a more superior one here. We did the same thing, incrementally advanced it and looped it in place. And this was the final position of that catheter. And then a very similar case, this patient had an anterior abscess and under CT fluoro, just popped the catheter in and deployed it, and nice quick abscess drainage procedure, and no mess or fuss with a guide wire that you could end up kinking into in a small collection like that.
Nice. Well, I have a question. You know, every now and then we encounter cases where the tissues are rock hard. How do you handle with these situations?
Yeah, that can be a really frustrating situation. And especially for the inexperienced operators, it can be like, you know, a very difficult situation and often unsuccessful. So when your classic scenario is like the patient that had pre-op chemoradiation for rectal cancer and then underwent a proctectomy and post-surgically has an abscess, and there's all this fibrotic tissue, you know, especially if it's a chronic abscess with chronic inflammation and post-radiation fibrosis. And so this can actually be rock hard tissue. Getting the catheter in involves many steps. You know, we don't usually trocar these because it's so hard to trocar a reasonably sized catheter through fibrosis. So we usually use Seldinger, and getting the needle in is usually pretty easy and the guide wire, but then dilating can be a problem and getting the catheter in can be a problem. So once you have the guide wire in, you want to dilate, and the dilators kind of present conflicting or opposing issues. One is that the smaller the size or diameter of the catheter, the smaller the French size, the easier it might slip through the hole into the collection, but it's also a more flimsy dilator. So sometimes starting with the smallest dilator first is good, and then you just go up 2 French sizes at a time. But sometimes you can't get the small one in because it's so stiff, and you have to start with a little bit of a larger, stiffer dilator and then push that in. This next case, actually what happened was we got the needle in and the guide wire in, but we couldn't push any of our dilators through the fibrosis, and we weren't sure we were going to be able to complete this successfully. But when we put our catheter over the metal stiffener into the collection with a lot of force, we were able to pop it over the guide wire into the collection. So that was good. One of the pitfalls is that the catheters all have some tendency to buckle. You want to use a catheter that has very little tendency to buckle, that's very stiff. That's helpful. And then if you think about it, if you're able to advance the catheter by holding the catheter closer to the skin, there's less length of catheter to buckle. So less of the energy goes into buckling and more goes into advancing the catheter. And then one of the most critical things is how you handle the guide wire. And what I mean by that is you don't want to hold the guide wire daintily like this. You want to hold it very firmly. And so instead of this, grab it very firmly and hold the guide wires fixed in space, and then advance the catheter by grabbing the catheter right next to the skin so that you're using the very short distal part of the catheter to push. And then if it's a really stiff situation, you may have to use both hands. And what I mean by that is with one hand, you may want to grab the hub and this clear plastic hub of the metal stiffener so that you're literally pushing the metal stiffener. And then with your other hand, you're also grabbing the catheter near the skin and pushing there. And that can allow you to use a lot of force, minimize buckling, and help you push through fibrosis. But then you need an assistant to really hold the guide wire firmly for you so that it doesn't go with the catheter. So it's going to look something like this. You're holding the hub and the catheter near the skin and pushing hard while somebody else holds the guide wire. So just to illustrate the problem with kinking the guide wire, if you allow the guide wire to go with the catheter or with the dilator, then it's very easy for this guide wire to kink as you advance the catheter or dilator. On the other hand, if you hold the guide wire absolutely rigid in space or even pull back a little bit, put a little traction on it, then the guide wire will act like a rail and it will not kink as you advance the catheter over it. The only possible exception is when you get to the back of the collection. If you push the guide wire against the back of the wall, it could kink there. And then, even with biopsies, you can encounter very hard fibrosis sometimes. And I've had situations where my core biopsy stylet bends. And when this happens, just be careful. You don't want to break the stylet off inside the tissue. So you may just want to pull the whole apparatus out without retracting the stylet and put in a larger gauge core biopsy device to sample the tissue. And even then, you might just push the core biopsy needle before you deploy the stylet into the mass, and then deploy the stylet as you pull the rest of the needle back. And then finally, there's high output drainage situations or viscous collections can be problems. And just a couple of comments on that. For example, this was an abscess that we initially drained with a 14 French catheter and drained it successfully, but it just had such high output that we couldn't keep up with it, and it just kept refilling. So you can either put more catheters into a collection like this to try to keep up with the output, or sometimes we'll put in a Gordon catheter that's anywhere from 18 to 22 French or so. I usually don't start with a Gordon because I find that if I start with a 20 French catheter, I'm more likely to get a septic episode. I'll start with a 14, then upsize later to the Gordon. The only problem is the Gordon doesn't have a locking loop, and you have to make sure all the side holes are in the collection. And then you just stitch the catheter in place at the skin instead of using an adhesive fixation. Some abscess collections are just too viscous. This was a Crohn's patient, and we easily got our catheter into the abscess, but even with irrigation, it wouldn't drain. And once we started using TPA, it drained beautifully. The only thing is we don't like to use TPA if they're at high risk for bleeding in the craniospinal axis, like if they've had recent surgery in the brain or spine. And then the other thing is I don't like to use it for pancreatic collections. I find I had one case where I tried it and it reopened a pancreatic leak. So we don't use it for pancreatic collections unless they're non-communicating.
That makes sense.
So, Dan, we're kind of at the end, and I thought a nice way to close out would be a case that you have that kind of reminds us to keep our thinking caps on and consider everything that we're doing and actively think while we're doing the procedure.
Absolutely, Paul. It's very tempting to use all the strategies to get to the biopsy, and in our busy practices, lose track of what we're doing and get a little bit of a tunnel vision. This is a case where I was definitely with the tunnel vision, and I got lucky. The patient had a lung mass, liver lesions, and adrenal mass. Presumably suspected metastatic lung cancer, was referred to me for an adrenal mass biopsy. As we showed earlier, we placed the patient on lateral decubitus for the biopsy. The lung was in the way. We tried to reposition the patient. As we were repositioning the patient, I felt like the nodule was a little too low density. I decided to measure the Hounsfield units, and actually the nodule had a non-contrast density of less than 10 Hounsfield units. So we're actually dealing with an adrenal mass that was hypodense, a diagnostic of a lipid-rich adenoma. It had nothing to do with the metastatic disease. With that in mind, I took a step back. I said, well, I looked at the images that we had for the procedure for the adrenal mass, and I felt that I could possibly biopsy the liver lesion. I repositioned the patient for a liver mass biopsy at this time. I didn't have a good window, and that actually was, retrospectively seen now, repositioning the patient, trying to get the patient to a more favorable position for a liver mass biopsy. It made me think rethink the entire procedure. So I went back to the CT, I looked at the images, and I said, well, why don't I actually do a cervical lymph node biopsy? The patient had a very large cervical mass. So we brought an ultrasound machine. We looked at the patient's neck. We could see a large heterogeneous mass in the left supraclavicular fossa. And we ended up performing a pretty straightforward biopsy by using ultrasound and obtaining the specimens we were actually looking forward to obtain. And this was confirmed small cell carcinoma of the lung. So always think outside the box, make sure, tissue is the issue. And if there's this easier way to obtaining the tissue, it's almost always the straightforward and safest way.
It's such a great point, Dan. And, we sometimes, if we're get a little bit lazy, when we get referred a case to do something, the referrers often don't understand the imaging or the findings. And if we're not thinking, we can sometimes kind of be led down the garden path.
Absolutely.
Well, so that wraps up our presentation, and we want to thank you for your attention and hope this was helpful and that you had learned a few things during this presentation. Feel free to contact either of us if you have questions. Enjoy the rest of the meeting.
Absolutely. Thank you very much. It was a pleasure to present this with you, Paul, and an honor. Thank you very much.
My pleasure, Dan. Take care.